My name is David Cheng, and today we'll be talking about EMGs. And the primary goal for today's talk is to understand the decision-making process of when to order this test and also what to do with the test results. I have about 20-30 minutes or so to go over this, and happy to address any concerns or questions at the end. I have no financial disclosures as relates to this talk. We'll be talking about basic concepts and clinical utility of the test. At the Spine Center, one of the primary reasons that we entertain the possibility of using electrodiagnostic testing is in patients with radicular symptoms. That said, radiculopathy, both in the cervical and the lumbar spine, can present as diagnostic challenges. We know that the diagnosis is clinical, but there are other non-spine problems that can mimic radiculopathy. And there is no gold standard for diagnosis, and also the imaging sometimes can be confusing. If we're talking about neck and upper extremity symptoms, a lot of the orthopedic entities such as AC arthritis, shoulder impingement, and even some elbow and wrist problems such as lateral epicondylitis, orthic Werving's tenosynovitis, all those things that can cause pain either in the shoulder, elbow, and wrist, especially in someone who has baseline neck pain, can make the diagnosis confusing. Electrodiagnostic testing can therefore be considered for someone who has not a classic kind of presentation of these symptoms, and it helps us answer very important questions. Even though we casually refer to this category of test as EMG, in fact, it's just one part of the test. More accurately, it should be referred to as electrodiagnostic testing, and it consists of two parts. One is the nerve conduction study. That's the shocking part. And the second part of the test involves electromyography. This is the section of the test where we use a thin needle electrode and check for electrical activity in certain muscles. We can think about this test as an extension of a clinical exam, and it's a way for us to assess for peripheral nerve injury. I think that last part really bears repeating because, number one, it is not a test to look for reasons for nerve pain, but rather for nerve injury. And secondly, there are some limitations for this test as well. For instance, small fiber neuropathy is not assessed with these techniques. The next thing I'd like to talk about is routine nerve conduction setup. And I think that for those of you in attendance, number one, thank you. It's helpful to know where the leads are, where the electrodes are placed. And I think this can give you an idea of the type of information we can gather from this test, but also the type of information that we can't get. For instance, in the upper extremities, for the motor conduction study, the electrodes are placed routinely over the median nerve, and the destination muscle is APB, so that's just over the thumb. It's a C8T1 muscle. And secondly, the second muscle to be tested is ADM, over here over by the pinky, and it's, again, a C8T1 muscle. Sensory nerves for median and ulnar are considered routine nerve conduction studies in the upper extremities. In the lower extremities, the routine muscles to be tested are the EDB and the abductor hallucis, respectively. The reason I mentioned this slide is that, number one, if we are looking for someone with radiculopathy causing weakness, really we can assess from the first part of the test really injuries that affect C8 or T1 in the upper extremities, or L5, S1, and sometimes S2 in the lower extremities. Anything outside of that, the first part of the study is not very helpful. It can help us to tease out other peripheral nerve entrapments, but for radiculopathy in an isolated problem, the first part of the study, the nerve conduction study, is not really that useful. We really rely on the second part of the study, the needle testing, where we can be more particular about lesions that are different than what you see in this slide. There are several goals of electrodiagnostic studies, and I mentioned them here, specifically for radiculopathy, specifically for our purposes in the Spine Center. We care about identifying the problem, localizing the lesions. So for instance, if there are multi-level foraminal stenosis in the neck or low back, we want to know exactly which level is causing injury. And lastly, to assess for the chronicity of that injury. In terms of the type of things that the test is able to identify, we can identify primary motor neuron problems, nerve root issues, and then pathology distal to that, including the plexus, peripheral nerve, neuromuscular junction, and muscle. One thing that's important to note here is that in radiculopathy, even patients with this type of problem and sensory impairments, the test actually comes back normal because the lesion is proximal to the DRG, or the dorsal root ganglion. So we'll talk briefly about the nerve conduction study and kind of the mechanics of this. Here you see my arm on the right side, and we're going to go over some parameters and what they mean. This is a setup for the median nerve, and the very first thing that you see is latency. Latency effectively is the amount of time that it takes from the delivery of the electrical stimulus to where the stimulus is picked up. So you can see that over here on the right side, you have the stimulator wand, and then you have the recording electrodes over my thumb. So the latency is the amount of time that it takes for the stimulus to be delivered by the wand, and the time it takes to reach that black or active electrode. And it's measured here in milliseconds. I have provided for you a chart of reference values on the bottom. So effectively, we're looking at this chart here, and so we're seeing that the latency measures 5.35. We compare that to normal latency, which should be less than 4.5, and we would say that this is prolonged latency. So in other words, it's taking longer time to go from here to here. The second thing we'll look at is amplitude. Amplitude very simply describes the height of that signal, and effectively it represents two things. Number one is the number of healthy axons, and number two is all the muscle fibers that are supplied by those axons. And you can see that the amplitude for this example is 11.3 millivolts, and normal is greater than 4. So we would say that the amplitude is normal. Talking briefly more about amplitude, you'll hear some terms that I like to define. So a motor unit here is defined as a motoneuron, the axon, as well as all the muscle fibers that are connected to it. And when we're looking at that amplitude, we're essentially looking at a summation of action potentials. And this is why it's called compound muscle action potentials. So it's a sum of many motor units that you see here. So many motoneurons, axons, and all the muscle fibers. Lastly, for the motor conduction study, we'll talk about conduction velocity, and that effectively is the speed at which the signal is transmitted from the proximal to the distal stimulation. When we're talking about the median nerve, we know that there are two stimulations. One you saw earlier as at the wrist, and the second one is at the elbow. So effectively, this is the amount of time that it takes to go from the elbow to the wrist. In the upper extremities, you can see that the standard is over 50 meters per second, and the example given here is 61.8, so that would be also normal. So putting everything together, we know that there is prolonged motor latency, normal amplitude, normal conduction velocity, and this is a very classic textbook finding for someone with carpal tunnel syndrome or motor median neuropathy at the wrist. We're going to switch gears here a bit and talk about sensory nerve conduction studies. Effectively, it's very similar, except that there is no neuromuscular junction. So here, the conduction velocity is really the same thing as the onset latency, and you can see that here, the onset latency is the amount of time that it takes to go from 0 to the first mark that you see here, and that can be calculated to 37.8 meters per second, which is slow. The second part of electrodiagnostic testing is EMG, and that is a very important component of this test, particularly in cervical or lumbar radiculopathy. Some basic things that I would advise when I'm speaking to a patient who's never had this done before, which is that a normal muscle should be electrically silent, and we're choosing these muscles depending on what we think the problem might be. Spontaneous activity describes really normal activity when the needle goes through the muscle. It causes irritation to the muscle membrane. It can cause also a release of electrical activity. And we would be checking for the activity in several parts or 3 different depths in 4 quadrants of a muscle. That spontaneous activity, if it's prolonged, that can indicate more serious problems. And the next slide will show us some examples of that. For those of you that take care of patients with spine problems and radiculopathy in particular, you'll come across the terms fibrillation and positive sharp waves frequently when you're reviewing electrodiagnostic testing report. And those terms effectively mean that there is spontaneous depolarization of a muscle fiber that's prolonged, and it's a marker of active or ongoing denervation. And the findings that you can see on the screen also comes with a fairly recognizable and audio recording. And basically you would hear regular firing pattern. In other words, it's kind of a tick, tick, tick type of sound, and the time interval between those sounds are exactly the same. That's what I mean by regular firing pattern. The second part of the test, the EMG, can also be helpful for us to localize the disorder. And here you are seeing that we're going from the left side to the right side, from distal to proximal. And you can see that for a distal problem, provided that there is motor axonal loss, there are fewer muscles that are involved. And clearly, if the problem is higher up, it affects many more muscles downstream. So we're looking at patterns in electrodiagnostic testing, and basically it's the pattern of weakness clinically and pattern of weakness electrophysiologically that helps us come to a conclusion as to where the disorder might be. Other things that we're looking for outside of abnormal spontaneous activity is motor unit analysis. This gives us information about the chronicity of the problem as well as the presence of reinnervation. What you're seeing on the left side is 2 healthy, happy motor units, healthy axons and neurons. And what you see on the right side is that the axon of cell B is injured or is cut, marked by that red line there. And in early stages of reinnervation, you will see sprouting. And so you can see that from the healthy motor unit A, that there is some sprouting here to the affected axon, axon B. So in early reinnervation, this sprouting is thin, it's not very myelinated, and for that reason, the transmission of signal is delayed. And so what you're seeing here is that you're seeing a major spike that belongs to motor unit A, and then you're seeing the satellite potential that trails after the major spike. And those are essentially all the muscle fibers that are now connected to the healthy motor unit A through this young sprouting. And so as this process matures and we get to the late reinnervation, and what happens is that the myelin is now placed, and that satellite potential that you saw earlier gets closer and closer, so that as far as speed, and eventually it gets incorporated into that major spike. So now what you're seeing on the right side, a neuropathic motor unit action potential, is one that has had the opportunity of reinnervation. Typically, we set this to, we think about these type of phenomenons as at least a 3-month period, chronic reinnervation. So you're seeing that this motor unit is now giant. So the amplitude is really big. And this helps us to understand where we're catching the patients in this reinnervation process. And so it can be pertinent, particularly when we're seeing someone with, let's say, a foot drop, and we want to know how long has that been there, as when we're counseling patients regarding treatment options and treatment expectations, whether that injury is old versus new, whether there is presence of reinnervation or not, can have implications in terms of prognosis, and that allows us to better guide patients. This slide really is a reflection of that, is that through the needle study, we can tell how long the problem has been going on. We can see here fibrillations and positive sharp waves, typically able to pick that up around the 1 month mark. The chronic findings is basically any time we're seeing some remodeling to the motor unit. That can come as polyphagia, so lots of different waves, because the satellite potential is firing asynchronously with the major spike. Or if the problem has been going on for a long time, and that satellite finally joins the major spike, then we're seeing that increased MUP, or motor unit potential amplitude. In the last few minutes of my session here, I want to go through some real quick samples, clinical examples, and some medical decision challenges. Number one here is making sense of a normal test. Well, the first thing that we would do is just figure out whether it is a technical issue. Timing of the test can have an effect on whether the test shows abnormalities. For instance, we talked about the needle test being probably most accurate at the 4-week mark. So anything before that time, unless we're talking about avulsion or something like that, it may show up as a false negative. Secondly, the nerves and muscles that are tested are crucial depending on where the expected level of pathology is. For instance, we mentioned the nerve conduction study for the upper extremities are really testing C8 muscles, or for testing it. If the concern is for a C5 reticulopathy, it's no wonder that those tests would come back normal. And this goes without saying that if the muscles are tested are not a C5 innervated muscle, this test will be of no use to us. Next is that a normal test does not preclude painful reticulitis, inflammation, not injury, or stenosis. And the last point here, I've already mentioned that because the lesion is proximal to the DRG, someone with a sensory complaint and imaging findings suggestive of reticulopathy, it may still come back normal. So we'll go over some sample cases here. Patient with cervical spinal stenosis presents with weakness, numbness, and poor balance. The clinical impression here is that it's cervical myelopathy. This test would be normal. The EMG will be normal, or electrodiagnostic test would be normal, because the test looks for a peripheral lesion, and cervical myelopathy is the upper motor neuron lesion. Example case 2 is neck pain traveling down the arm. This is cervical radiculitis, but there's no nerve injury, and therefore the test is normal. Third example is someone with neck pain with numbness going down the arm. This is a sensory cervical radiculopathy, and based on what we talked about, the test is normal. The fourth example is neck pain traveling down the arm with weakness. And we know that this is cervical radiculopathy with motor axonal loss, and the test can potentially be abnormal. If, let's say, the first part, it does involve, in fact, a C8T1 radiculopathy, in which case the amplitude that we saw would be decreased. And secondly, the needle test may also be abnormal based on exam timing and muscle tested. And so I think that the take-home points are the test, if we are very confident that this is radiculopathy, you need to be very mindful of what exactly the test can add to our medical decision-making process. You know, in someone with concerns for double crush injuries, such as a carpal tunnel plus neck pain or plus cervical radiculopathy, I think those tests can be helpful. Electrodiagnostic testing can show up as positive in subacute radiculopathy with motor axonal loss. It's used just like any other diagnostic test, including imaging, to increase the precision of the diagnosis. And before ordering the test, it's particularly because there's some stimulation involved, there's some needles that are involved. It's not the most comfortable test. We want to make sure that we're recommending this test for the right reasons, to consider the disease prevalence. What is the likelihood that this test, number one, will show abnormal things, and how does that affect our treatment plan? I thank you so much for your attention.